Good afternoon.
Good afternoon, Madam Chair.
I've missed that. Today is Thursday, January 22nd. You are in the Senate Finance Committee, and we are happy to hear today from the Maryland Health Benefit Exchange. So if Executive Director Michelle Eberly will come to the table with her deputy, Joanna Fabian, and please begin your presentation. Thank you.
Thank you, Chair Beidel, Vice Chair Hayes, and members of the committee. Thank you for having us here today so we can give you a briefing on what's going on with Maryland Health Benefit Exchange and Maryland Health Connection, which is our the marketplace. Just a quick overview. We were created out of the Affordable Care Act 2010, and we are an independent unit of state government. We provide, we're the only place where you can come get, or where you can get financial assistance, whether it's through federal tax credits or through state premium assistance program, reinsurance program. And we serve over 1 in 4 Marylanders, and that's not only the modified adjusted gross income Medicaid population, but we also have the individual marketplace, we have a small group marketplace, and then we also offer standalone dental and vision plans. So quite a lot of Marylanders use Maryland Health Connection. We did note when we went through the public health emergency unwind and we did some outreach to find out, do people know about Maryland Health Connection, and the surveys came back overwhelming. Yes, Marylanders know that Maryland Health Connection is the place to go to get health insurance, so we are really thrilled with that. I'm going to talk a little bit about our open enrollment experience this year. And in fact, I just got off a press conference with all my colleagues from across the nation that do state-based marketplaces. I think there's 23 of us now. And we felt it really important because this year the message is you have to look deeper than what's being reported at a national level. So we're hearing at a national level that, well, we know, we'll just start with those, the expanded tax credits were not extended after December. There's still some talk at the federal level of something occurring this month. We do not hold out any hope for that occurring. So now we're in a place where we're hearing the message, well, enrollments aren't down that much, and these were all fraudulent enrollments. These are people that really shouldn't have gotten enrolled. So those expanded tax credits are really not needed. We're really telling what the real story is. Maryland, thanks to your efforts, thanks to the administration, thanks to all our partners, we have been at the forefront of providing quality, affordable health coverage since our implementation. We did that through the reinsurance program first. We did that second through the Young Adult Subsidy Program, and most recently, as of last January, or last session, where we passed the State Premium Assistance Program. Maryland continues to have the lowest bronze and gold plan premiums in the nation, and we continue to do quite well. So if you look at our enrollment picture in Maryland, we had our highest enrollment ever. We have over 255,000, to be exact, 255,612 people were enrolled in health coverage. That's an increase of 3.4% from last year. Now, one thing to note, last year we had a significant increase in enrollments because we were coming off the public health emergency. So that gave us a lot of new enrollments last year. But what's important is that people that come back, we look at who's staying in coverage, who feels the benefit of that coverage, so they're not only enrolling, but they're staying. And we've done a pretty good job of keeping people enrolled. I'll talk about that in a minute. What I do want to point out is that our new enrollments are down significantly. So people that came to the exchange new this year, and again, part of that is because we're comparing against a public health emergency unwind last year, but the other part is that for many people it's not affordable anymore. And then our disenrollments are up significantly year over year compared to what we have. Also significant is the amount of people that were receiving premium tax credits. Federal premium tax credits has decreased, and those without the premium tax credit has increased significantly. I'll move on to the next slide, and I'll talk about, what all that means. So the state premium assistance program we offered, we were able to, through a lot of effort with the MIA, working with actuaries, looking at how much could we, afford to put into this program and not destabilize the reinsurance program, because that's where funding came from. And where we landed was we were able to backfill the expanded premium tax credit up to 100% of what was being lost for families earning up to 200% of FPL. And just as a guidance, it's for one individual, it's about $30,000. For a family of four, that's about $60,000. So we kept that population intact. Between 200 and 250, we did a sliding scale and went down, a little lower as we went on. The challenge for us was that anyone earning over 400% federal poverty level, and that's a little over $64,000 for an individual, for a family of four, a little over $128,000. They lost the expanded tax, or they lost all the tax credit, because we couldn't. Federal government said we're not going to do anything for over 400, and we couldn't backfill that. So as a result, what we saw, which is a good thing, people want health insurance. So we saw those people, we saw a big shift in folks saying, all right, I want health insurance. I can't afford the gold plan that I have been having. The gold plan that had $1,000 deductible, the gold plan that had very low copays, low co-insurance, very robust coverage. I can't afford that anymore, but I don't want to lose health insurance. It's that important to myself and my family. So they shifted down to a bronze plan. A bronze plan, most of our bronze plans carry $10,000 deductibles. So now that financial burden for medical has gone up tenfold for that family. At the same time, they were using taxes that they were paying to the federal government to help them pay for their health insurance. Well, they still have to pay those taxes. So essentially it was a double whammy. Your financial risk is going up, but now you're actually paying more in taxes to the federal government because you can't use them for your health insurance. In that category of the gold to the bronze, we saw the largest 31% are consumers over the age of 55. This is our pre-retiree individuals, or pre-Medicare, I should say, individuals. These are entrepreneurs. These are higher earners. And in fact, the other highest category is everyone over that 400%. Another area to make note of is under 100%, and this is directly related to what came out in federal law. We saw for the lawfully present immigrants that earn less than 100%, they were able to get tax credits. So some of them may have been over the age of 65, and they were not in the system long enough to qualify for Medicare, the work system. They could be, just not eligible, again, for Medicaid under the 5-year bar. We had about almost 1,500 people lose coverage in that category, and again, significantly over age 65. So again, these folks are folks that may be completely out of coverage. We won't know the full story and the full impact until we get to the end of March, beginning of April. And the reason is, if you're new and you're purchasing health insurance, you're enrolled, which are the numbers we report, but you're not what we refer to as effectuated. Your coverage does not become active until you pay that first bill. So we know sometimes people enroll and then life changes or what have you, and they won't pay that bill. For our renewal population, there's two categories. So for consumers that don't receive any federal tax credit, if they don't pay their premium and they're a renewal, they have up to 31 days before the insurance carrier will send us a termination file. If they receive premium tax credit, there's a grace period of 90 days. So we won't know the full story to see who's not going to pay for their premiums and just can't tolerate that within their other finances. So that will be at the end of March or April, and we will certainly keep everyone updated. So I'm going to talk just briefly about the federal marketplace changes because I wove it in my the open enrollment, and then turn it over to Johanna to dive deeper into the reinsurance and the premium assistance program. Again, all of these rules, we had the final program integrity rule came out in June, followed by the One Big Beautiful Bill Act that came out in July, and then followed by the enhanced premium tax credits, which were not renewed by Congress. All of these efforts make enrollment more difficult, restrict eligibility, reduces affordability, and we saw what plays out with the enrollment numbers that I just gave you. DACA, just really quickly, we lost about 300 Marylanders, deferred action childhood arrivals in September. We had to just terminate their coverage mid-plan year. And then I talked about the 20,000 Marylanders lawfully present. We're going to see another impact of that coming up in October 26, where Medicaid also will have a lawfully present immigrant impact. We expect for that, another 20,000 additional Marylanders. Well, no, I don't have the number for that. The additional 20,000 is the effective date change. So next year will be the first time in many years where the open enrollment period will go from January 1st to December 31st, and that we'll lose 2 weeks of enrollment. Let's see, did I miss anything else? Impact, okay. So this just is, it's in your packet, I won't go over it. It just shows how that enrollment has been. And again, we were anticipating significant losses. Instead, what we saw is significant additional financial burden placed on the consumer is what they chose. All right, I'm going to turn it over to Johanna. You want to scoot?
Thanks, Michelle. So as Michelle mentioned, I'll go into a little greater detail on our state premium assistance program and the current updates on the reinsurance program. So as you know, and as Michelle mentioned, the state enacted a state-based individual subsidy program last year that went into effect January 1 of this year for individuals who lost the enhanced federal premium tax credits that ended on December 31st, 2025. That work by Maryland, again, as Michelle mentioned, really successfully stabilized the individual market. And in fact, as of now, we saw slight growth in our enrollment. And again, we'll see how that plays out over the coming months, but we're certainly doing better than most other states around the country because of that action. The way the premium assistance is structured for individuals up to 200% of the federal poverty level, we fully replaced what they lost from federal premium assistance. And then for those up to 400%, we replaced half of what they lost. In addition, young adults get extra premium savings because we folded the prior young adult subsidy program into the overall state premium subsidy. Individuals do not have to specifically apply for the program. We implemented it such that we assess their eligibility when they're enrolling through Maryland Health Connection, and we automatically apply the premium savings to their bill if they are eligible. So we really wanted to minimize the friction to the enrollees so we would have the desired effect of keeping people in coverage. The premium assistance program is funded by the state premium assessment that was originally established to support the reinsurance program, and I'll cover that more at the end of my presentation. Just an update here on enrollment in the state premium assistance program. We have over 177,000 Marylanders receiving the state premium assistance at an average of about $94 per month. And then of those 177,000, almost 71,000 are young adults age 18 to 37 who are getting that boosted premium assistance this year. This is just a little bit of detail on what we expected to happen if the state had not enacted the premium assistance program. These are projections that we put together late last year as we were designing the final shape of the premium assistance program. And without it, we anticipated that of our 190,000 enrollees who were losing the enhanced federal premium tax credits, they would experience a 95% net increase in their premium, and 90,000 of them as a result would choose to drop coverage. Our projections were that with the state premium assistance, we would cut that net premium increase by 2/3, and we would cut that projected enrollment loss by 2/3. As our initial data shows, we may outperform that, but we are still keeping close tabs on that because we don't know how many people will ultimately decide not to pay that January bill and drop coverage. So these numbers are still evolving. Nevertheless, we really, we projected a significant impact from the state premium assistance program, and we are seeing that in the data. And then I will transition now to just a few quick updates on the reinsurance program. So the General Assembly put this program in place in 2019, as many of you know and remember, to stabilize the individual market. Prior to 2018, as we see in this graph, we were seeing double-digit premium increases in the individual market, and they were going up year over year. Starting in 2019, with the implementation of the reinsurance program, we saw significant decreases in premiums and then moderate increases in line with trend thereafter. We did return to low double-digit increases in 2026 due to all the federal changes that we've discussed, but that was still significantly lower than many other states experienced for 2026. In total, the reinsurance program reduces premiums in the individual market by about 1/3 relative to where they would be without reinsurance. And you can see in this graph how implementation of reinsurance stabilized our enrollment. So as those premiums came down, we can see that dip in 2018, 2019 stabilized, and enrollment started to grow. So just a quick recap on how reinsurance works. Through reinsurance, the state reimburses insurers for a portion of their claims, currently about 1/3 of their claims costs, and that allows carriers in turn to reduce their premiums, again, by about 1/3 relative to where they would be absent the program. We operate reinsurance under a waiver from the federal government, which is approved in 5-year increments, and the current waiver period ends at the end of 2028. And then we fund reinsurance through several pots. First, we use state funds derived from a 1% assessment on most state-regulated health insurance. And then that 1% assessment was less than we needed for the program in the early years. On top of that, in the first year of the assessment in 2019, it was actually 2.75%. So through the early years of the program, we were able to build up a reserve. That reserve we are now drawing upon to support the state premium assistance program, and it is there to stabilize the market, so we are using it as it is needed now. And then we also get federal funds for reinsurance. That funding varies each year. It's tied to the Fed's calculation of how much money the reinsurance program is saving the federal government as a result of reinsurance driving down federal costs for the premium tax credits. And that federal funding does provide the majority of funding for reinsurance. Here's a bunch of information in a graph that shows our funding experience and projections for 2026 for reinsurance. You can see the annual funding that's coming in to support the program in the bars. Green shows the federal funding we receive each year. Blue shows the state funding collected as a result of the assessment I mentioned. The red line shows the annual cost of the reinsurance program, and the purple line shows the state reinsurance fund balance each year. You can see, as I mentioned, that grew in the early years as costs came in below the total funding we were receiving, and we'll be drawing down on that fund this year to support the state premium assistance program. I do want to note the 2025 and 2026 costs are projections, as are the 2026 funding numbers. And then the last item I'll mention on reinsurance today is just to discuss what's on the horizon. So as mentioned, the current waiver, as well as that 1% state assessment that funds it, sunsets at the end of 2028, absent state action. This year, our board will be closely monitoring the state premium assistance program expenditures and will continue closely monitoring reinsurance. Taking into account all of that information, the board will set 2027 reinsurance and premium assistance levels, considering available funding and the importance of maintaining the solvency of the reinsurance fund through the end of the waiver period. And then as we look to the future with the upcoming sunset of the reinsurance and the assessment, in 2027, we as a state will be faced with determining whether to apply to the federal government to extend the reinsurance program, and we'll also need to decide whether to continue the assessment. And we are having conversations with all of our sister state health agencies at the moment around how the state can best support affordability for all of our residents going forward. So this is one piece of those larger conversations. And I think that's the end of our presentation.
Thank you. Do you have any questions from senators? Senator Lamb.
Yeah, thank you, Madam Chair. So a question, great presentation, a lot, packed in there, I guess. Is it fair to say that based on what you were describing, it sounds as though even in spite of the increased costs, there's been some additional help with subsidies. Most beneficiaries are trying to still pay, what they can to stay on health insurance, even at that increased cost. So they're trying to hang on, I guess, right? We're losing some of them, but they're hanging on.
Yes, that's exactly what we saw, is that people want health insurance. And that young adult subsidy program, we saw that 9% increase in that. So these are, if it's affordable, people want health insurance. And we still had new enrollees. We were surprised that we had so many new enrollees, but that state premium assistance program really worked. And then you can see on the other side, when it gets where it's unaffordable for the over 400%, that's where we lost coverage.
Right. So people are willing to pay even a little bit more. They're digging deeper into their pockets to just try to hang on to their insurance, or at least qualify, be able to afford something on the exchange, even though it's costing them a little bit more.
Well, and I can't say it's costing them out of pocket more because they're moving from a gold premium, which is a higher cost monthly premium, to a bronze premium. So it's not necessarily on a month-to-month basis and their premium costing them more, but their medical risk is now increased. And what we often find is that people will then defer getting treatment because if they know that they have a co-insurance for a planned surgery, and we also know that right now, I think Controller Learman said it in a press conference we were in, that most Marylanders don't have $1,000 in their savings account. So if there's any shift, the car breaks down, anything happens, there's going to have to be tough decisions made of what to fund.
And you said above 400% federal poverty level, they're no longer getting anything. What was it before? Like, where were you gave a lot of the benchmarks of where the cutoffs are now, but where was it before?
So pre ARPA, there was a cap on it. Post ARPA, that cap was removed. So people over 400% got something, and was 8.2% or 9?
Yes. Once the federal government expanded the tax credits in 2021, they took off a strict income cap, and they just set a cap such that you would never have to pay more than 8.5% of your household income for a benchmark plan. So that was kind of a moving target depending on where your income was, but it did allow higher income individuals, especially older individuals who have higher premiums, to get more assistance.
And you may recall that was referred to as the cliff.
Right. Okay. In one of your slides, you showed that the fund balance is now going down because you're drawing into it, right? So it was going up for a while, costs were lower for a while. Now costs are going up, fund balance is going down, right? So I guess, the balance was built for a time like this where you needed to really draw down from it, I guess, right? In some ways, so that makes sense. But how sustainable is this, right? Because we're seeing that delta kind of grow in that one of those charts where there was the purple line, the red line.
So when we spoke about the State Premium Assistance Program, we knew it was just a temporary stopgap. And we wanted to give Congress enough time to do what they needed to do. We have planned it, what we did for 2026. We know for 2027 we won't be able to do the same amount. And then the whole reinsurance program, because we had to keep the reinsurance program solvent through 2028. So as Johanna mentioned, next session, we're going to have to be looking as a state of what do we do with this, with the 1332 waiver? Do we continue it? What do we do with the assessments? What has Congress done? So there's a lot of things to consider. And next year will be really pivotal, and we'll be monitoring closely what's going on at the federal level, and then coming back with some thoughts and ideas of as a state how we should move forward.
So basically, we're patching things together right now, but in 2027 things could really hit.
Yes, and our goal was to minimize enrollment loss, because we know once we lose somebody from insurance, it's twice as much work to get them back in. So that was our main goal. Keep as many people covered. Don't have the reinsurance program become, insolvent. Don't harm that, but keep as many people enrolled in health coverage as we could.
And then last question, you referenced the 1332 waiver from CMS. Is there a risk if we decide to extend it that CMS would not approve our 1332 waiver if we requested an extension?
There's always that risk, but I will say the current CMS administrator, Nelson, is very supportive of 1332 waivers. So I don't think even with the administration that we have now that would be a significant risk. Do you feel differently?
Yes, and particularly supportive of reinsurance programs under 1332s.
Okay, so the likelihood is if we ask for a 1332 extension, we'd get it. Probably.
Believe so.
Fingers crossed. Yeah. Okay. Thank you.
Thank you, Senator. Senator Ellis?
Thank you, ladies, for your presentation. I want to take a deeper dive in the reinsurance funding experience. So my brain, when it hears reinsurance, I think of you have an insurance company, and then that insurance company is backed by another company. In this context, could you explain what the reinsurance is and who the insurer is and reinsurance?
Yes, and that is absolutely right. And in this context, the state is operating as that reinsurer. So each year we get a total of the insurer's claims from each insurer in the individual market. And based on parameters that the exchange's board sets, we will essentially reimburse carriers for a portion of their claims, and it works out in total to be about a third of claims.
Okay, thank you. So the insurer in this case would be like, give me one name if you can.
Care First,
Care First.
Kaiser.
The insurers, okay.
Yep,
And
so
then-
Care First, we work with them. They tell us these are our claims costs for 2025,
Mm-hmm.
and then based on the parameters of the program, we will reimburse them, and that allows them to reduce the premiums they charge.
Right. And then the state is considered the reinsurer. Who handles those funds? Is it the treasurer's office? Or
The Maryland Insurance Administration collects the 1% assessment that goes into the reinsurance fund, and the exchange administers the fund and the payments to carriers.
And the federal funding comes in through the exchange. And so we actually have a fund balance. And in fact, if you look at the budget for the exchange, it looks like we have a lot of money. But really, it's a lot of that reinsurance, which just is a pass-through, is that
okay,
pass-through.
yeah, okay. And is that pass-through that I was curious about? So you answered the question. So thank you so much. Appreciate that.
And one
Thank you,
other
Vicki.
thing I just want to add, because this, I think, is the other side of that. We hear often, well, we're just, we're subsidizing the carriers for this. So two important points. One is if the state did not provide that reinsurance, those costs would be split among everyone. And two, and in fact, our meetings are starting next week, we do require the carriers to submit carrier accountability reports, and they'll be coming in to do their presentations to tell us, how are you containing costs for these high-cost claimants?
Okay, great. Thank you. Thank you, Madam Chair.
Thank you. Do I see any other questions? Okay, thank you very much for your presentation and for the work that you do. We really do appreciate it. Thank you, Michelle. Okay.
Right here. Okay. Thank you. All right. Good afternoon, everyone. It's a pleasure to be here. I'm Marie Grant. I'm Maryland's Insurance Commissioner. I am joined by Brad Bobin, who is our Chief Actuary for Life and Health. If there are hard questions about numbers, Brad's going to cover them. So we're going to talk a little bit about the latest with United and some of the network contract disputes we've heard. We're going to talk about, I think Michelle and Johanna mostly covered what we're seeing in the individual market, but we'll talk about a little bit about that.
Madam Commissioner,
yeah.
I just want to welcome you. I was waiting for our manager, Tammy, to get back on her seat before I introduced you. That's okay. So thank you for being here, and we'll look forward to your presentation. So we have Marie Grant, Maryland Insurance Minister, with us. Thank you.
Great. Thanks so much, Madam Chair. Sorry to just launch in like that. So I think it was going through a little bit of our agenda. We also have several departmental proposals, most of which will be heard in this committee next week, that we will talk about just very high level and how they intersect with some of the consumer issues we've been seeing this year. All right. So I think, as most folks know here, negotiations between United and Johns Hopkins broke down this summer, and now for most services, Johns Hopkins is out of network with United Healthcare, which is a major carrier in our state and is of big concern, I think, to many of our consumers. The contract ended on August 25th. And just in general, as a regulatory agency, we can't force parties to contract. That really is a private, a contractual relationship between our insurers and our providers. But what we can do is we can make sure that our carriers have adequate networks to serve their members. And we've also been, we've been monitoring whether United is able to meet all of its obligations under Maryland law to provide an adequate network, and there's been ongoing dialogue with United over the course of the fall. The other important thing is when a health system goes out of network with an insurer, there are continuity of care protections under state and federal law. For patients. Right now, there's primary care that's protected for 90 days under Maryland law, and there are also complex conditions, things like pregnancy, things like if you're actually in the hospital when folks go out of network. If you have a complex condition that's hard to treat, you can also get 90 days of continuity care protection. We've been doing a lot of monitoring over the course of the fall to make sure those requirements are enforced. Unfortunately, we haven't seen any movement in negotiations with United and Johns Hopkins so far. High level, what both parties have shared is that the issue is not actually the reimbursement rate, but it is the utilization management practices with self-insured groups, which unfortunately are out of our authority. So again, we continue to examine United's practices here. We continue to keep in touch with both parties. The little bit of good news here is over the summer, United also went out of network with Capital Women's Care, which folks may know is a major OBGYN provider in the state, particularly in our national capital area, but really throughout the state. And they have just entered back into network with Capital Women's Care retroactive to January 1. This slide just presents a summary of regulations that we have in force around network adequacy. Carriers have to file annual access plans with us, detailing how they meet standards. And the access plans have to include things like scope of services, distance requirements and travel distance standards, appointment waiting standards, provider to enrollee ratio standards, and the impact of all of those were in a bulletin that we issued back in 2023. I will say this whole situation with United this past year is leading us to go back and look at those requirements, and we'll be doing that over the course of 2026 through regulation. Okay. Next, again, you've just heard in great detail some of the impacts of the loss of the enhanced tax credits. So I'll walk through these relatively quickly. This chart, and I'm not going to, is a complicated chart, but what it does is go through by income the impact of the change in subsidy, how we were able to protect individuals, and then what would have happened and the increases in costs that our low-income members would have seen had we not done a state subsidy. And so that state subsidy has really helped to protect Marylanders, I think, from the brunt of the increased cost sharing of the loss of the enhanced tax credits. So just the latest news from Congress, which unfortunately doesn't sound promising for an extension here. We did have the House of Representatives did in January pass a 3-year clean extension of the enhanced tax credits. However, a clean extension of that length is not expected to pass the United States Senate. So we do still have a bipartisan group in the Senate working on its own version. That would include a 2-year extension. It would include, you've just heard how there was no income cap, and the cap with the enhanced tax credits worked by limiting the portion of your income that can go to healthcare. This would place an affirmative income cap of 700% of the federal poverty level. And perhaps a minimum premium. In Maryland, we actually don't have $0 premiums. In some states, there's a lot of concern about this provision, but I will say in Maryland, because we have non-essential health benefits as part of our plan, most of our folks are paying a few dollars towards their premium. But the news there isn't that promising either, and as we get later and later into 2026, I think I would still say the hope is that something can be done because it will help us. It will help Marylanders in 2026. It will also help them in 2027 and beyond. But as each day passes, it is not clear the action is going to be taken. And I think as a state, we're going to have to regroup and plan without having access to these enhanced tax credits. So just, again, some key market trends, because all of this can feel like bad news, but I want to put a little bit of it in perspective. Marylanders continue to enjoy some of the most affordable rates for individual market coverage in the country. I don't know that anyone would tell you they feel that, but just in terms of premium across the country, we do have some of the most affordable rates, largely because of the effectiveness of that reinsurance waiver. We continue to have comparatively lower rates still since 2018. Our approved 2026 rates were 6% lower than the pre-waiver 2018 rates, and the waiver continues to keep rates about a third lower than they would be without it. And so the 13.4% increase that we approved really was driven by the expiring federal tax credits. And then in terms of, there was also increases in medical that was primarily driven by pharmacy. So in Marylanders, I think as you heard it in great detail from the exchange, continue to use both federal tax credits as well as the state subsidy this year to help afford coverage. And this is a little bit about the program, which you've heard a lot about already. So these are a few just examples of how the subsidy helped and then what situation folks would have been in if we didn't do something through the state subsidy this year. So a 40-year-old single person in Maryland earning about $31,000 a year, that's 200% of poverty, can anticipate paying a premium of $53 per month in 2026. And that's a 0% change from last year because we've protected folks up to 200% of poverty with the state subsidy. If the state hadn't implemented that, that same person would have paid on average $173 a month. So another example is a family of 4 in Maryland with adults age 45 and 43. And we use ages because there's age rating in the individual market that makes $80,000 a year approximately, can anticipate paying $419 per month in 26 versus $271 per month in 2025 for the same plan. That family's income is at 250% of the federal poverty level. So without a state subsidy, that person would have paid that family would have paid $568 per month this year. So again, there's increases, but we are really able to protect those families from a really significant increase. And then our last example is someone just over the 400% of poverty mark with adults age 45 and 43 that make about $129,000 a year. They can anticipate paying $1,400 per month for coverage this year versus $916 per month last year. That's a significant increase. They've lost their enhanced tax credits, and unfortunately, we did not have the dollars to help supplement those folks. So our last section of our presentation, I'm going to talk very high level and quickly about our legislative proposals that we'll talk in more detail about next week that reflect some of the consumer issues we've been seeing. So first of all, we have a proposal about material changes to provider networks. Unfortunately, I think it's our concern that disputes between large health systems and carriers, that we may not have seen the last of them. And there were tools that as a regulator, we wish we had. We think there could have been better notification to consumers. And this particular proposal would require some earlier notice, both to consumers and to us. It would provide continuity of care protections for behavioral health. And for disputes between health systems and carriers, there would be a 90-day cooling off period, which it would essentially create a continuity of care provision for all services when a large health system is involved. And then finally, the bill would create a 90-day special enrollment period so that patients in the individual market whose provider leaves a network can switch health plans if they have an individual policy. The next bill that we are seeking, we're in the midst of wrapping up a 2-year cycle of enforcement for mental health parity. And this departmental, I think, is really strengthening and clarifying some of our requirements for our carriers based on some of our lessons learned from this most recent enforcement cycle. We have a bill that is actually about we're seeing an increase when there's a lot of uncertainty around healthcare and increases in costs. We are seeing greater advertising and issuance of plans that don't meet standards under Maryland law, junk plans, fraudulent types of plans. This is a bill to try to deal with those situations. It's would subject to TPAs to penalties if they violate other provisions of the insurance article. What we've been seeing with some of these fraudulent plans is we can hold brokers accountable for selling them, but we can't always get the entity behind it. That's actually really driving the plans. And so this would subject TPAs to penalties for violating the insurance article in addition to just the TPA subtitle in the insurance article. We have a departmental designed to address a couple of pain points related to Medicare supplement plans in creating 2 discrete special enrollment periods without underwriting. And finally, we have a bill that allows folks essentially to enroll earlier on the SHOP exchange to effectuate their coverage that puts us in line with federal requirements for enrollment. And that's our presentation. We're happy to answer any questions.
Senators, any questions? Senator Lamb?
Yeah, thank you for that presentation. I know at the top you started with United Healthcare. It seems like, I guess it's a small sample size, but they've had issues with there's been, a conflict with Hopkins. There's been a conflict with Capital Women's Group, right? Is there something with United Healthcare that we need? Is there a broader trend here that we should be concerned about and considering and thinking through? Because United is obviously a very large payer and health insurer, cover a lot of beneficiaries across the state of Maryland. Are we seeing the tip of the iceberg of potentially more controversies with coverage for United, or is this just kind of circumstantial?
So I think, I guess let me talk a little bit generally about our enforcement, because I don't necessarily want to talk about a particular payer, but when we see complaints that are a trend, we do deeper dives in market conduct investigations. Sometimes those can take a long time to play out, but those are all tools and something we're very acutely aware of. In general, and I think why we're pursuing legislation about some of these contract disputes this year, I think we're really concerned that in times where resources are drying up, where Medicaid funding may be less, where costs are going up, it's going to create an environment for more of these disputes, I think, between providers and insurers, unfortunately. And so it's our hope, it's always my hope to keep consumers out of the middle on those particular situations.
Okay. Maybe we can follow up offline about more
Absolutely.
specifics on this.
Absolutely.
You also went through, there have been ongoing conversations about network adequacy. Obviously, you brought that up too, and you referenced a few different criteria that you would use
Yeah.
to gauge network adequacy. Is your sense right now that United is meeting those requirements, or are you still in determination of that? It wasn't clear to me whether there's a concern with adequacy with United, or if it's still kind of in process of working through your determination.
Yeah, I'm not trying to give you a wrong answer or not directly answer your question. I want to be careful about some of the sensitivities of what we've been investigating. I will just say this. The provider ratios that we have in our network adequacy plans, I do not think are adequate to meet the moment of where we are. And those are some of the things we need to update.
Okay, but you haven't made a determination
No.
on United's case
Yeah.
at this point. Okay. So we've been hearing, I guess, just an increasing number of complaints from carriers downcoding claims of various providers. You've been probably following this as well. Providers seemingly have been getting inconsistent feedback on what is the law in Maryland around this particular issue, and that's led to some confusion. So I'm wondering if you could explain that part of the law and why the MIA has not issued any bulletins, like maybe clarifying this for providers and payers.
Yeah. So this is something we're actually actively talking to providers about. I think as recently as yesterday, my team was on the phone with provider representatives in detail. Maryland, and I don't know that I can explain the ins and outs of Maryland law off the top of my head in relation to this, but in general, insurers are supposed to pay clean claims. And they're supposed to meet the claim for where it is, right? For a fully insured product. So again, for those plans I have authority over. So if there is a universal downcoding policy that is hitting the fully insured market, in general, that would raise a high degree of suspicion with our team. But what I want to be careful here again is there's some nuances around that, and I think we're having a lot of discussions to see if there are specific changes that would be helpful to give us broader tools to enforce those kinds of requirements.
But there's existing statute right now
There is.
on that, right?
Yeah.
And so what's the hesitation with issuing a bulletin with what you view as what the current existing statute draws the line at?
Yeah, there's honestly not a hesitation. I'd be happy to talk more offline about it. I think some of the complaints we saw this summer in the policies just wasn't clear that they were hitting our fully insured market, but I'd be happy to talk to you about ways we can clarify current Maryland law here.
Okay. Yeah, I mean, I think a
Yeah.
bulletin would be helpful. So,
Okay.
If you're open to it, would
Yeah.
certainly encourage that to be considered. But let's continue this offline.
Okay, great. Thanks, Senator.
Thank you.
Commissioner Grant, are you sitting on the Adverse Decisions Commission, or you have someone, a representative sitting on it?
I am sitting on it, and our team is staffing it. And that work group had an introductory meeting once we got all our appointments last year, and I expect we will be putting out more information for meetings soon.
We'll look forward to that report. Thank you.
Great, thanks.
Do I have any other questions for Administrator Grant? Seeing none? Are you finished? Have you presented
I'm all
everything?
done. For now, I come
No,
back.
you're doing a wonderful job. Thank you very much.
Thanks so much.
So we'll take just a minute break while our manager sets up for a bill hearing. We'll have one bill hearing, so give us a minute. Oh, I missed something. We have a whole nother briefing on this.